And they were like, we need to make sure. We're going to do our own pathology. And it turns out that I'm 60% estrogen positive, so I am not triple negative. And so I had other treatment opportunities open up to me.
Coming up today, the importance of pathology. What happens in a lab has huge implications for breast cancer patients. How a fresh set of eyes can change everything. Good morning, I'm Jessica Lovell and welcome to the Morning Medical Update. You probably never really think about what happens inside a medical laboratory. When you go to the doctor, you may have some blood drawn or maybe a biopsy, and it is sent off to some place, somewhere, to someone, and then both you and your doctor get the results and go over them. The lab can feel like a black box. But with breast cancer, what happens in the lab is one of the most important steps in getting the right diagnosis. Janine Kiesling introduces us to one woman whose treatment changed based on what happened in the lab.
I got a notification on my phone, oh, you have a new message or whatever in your chart.
Allison Lackey couldn't believe what she was reading.
And it said, highly suspicious of malignancy.
The message, delivered over a weekend, sent her searching for answers online.
Going down a rabbit hole that I didn't want to go down because that was a scary, dark place.
Unfortunately for this Lee Summit mom, things only got worse when she was able to talk with her doctor.
My initial diagnosis came through another hospital, and it was the pathology that they gave me came back showing that I was triple negative. That's a really bad diagnosis to have.
Allison says the fear in her was telling her to start treatment immediately, but her gut was telling her to get a second opinion. Friends and family convinced her to follow her instincts, and she says that decision likely saved her life.
The reputation mostly is why I wanted to go there, but I did have my friend from church did her treatment through KU and was very happy and actually recommended the oncologist and breast surgeon that I have.
As soon as Allison made her appointment at the cancer center, she knew she was in the right place.
They were able to make meetings, appointments with everybody I needed to see all within one day. Hello. So the oncologist, the breast surgeon, the radiologist, all of it in one day.
These are the first lymph nodes that drain the breast.
Even before those appointments, Allison knew exactly what to expect.
I hadn't even had my appointment yet, and there was a courier who hand-delivered a personalized packet from KU outlining who my doctors were and what to expect. And it was just so reassuring and wonderful that they made it personalized.
Allison's doctors at the cancer center scheduled her treatment immediately, but they weren't satisfied with the previous lab results from the other hospital, so they ordered their own. Turns out Allison was misdiagnosed. She didn't have triple negative breast cancer. On the day her treatment was to begin, Allison's doctors changed course and the tumor shrunk.
Take your baby.
Thank you. Thank you.
All right.
Okay.
All right, we're gonna back into your room.
Okay.
Allison had a lumpectomy to remove the tumor, and after a few radiation treatments,
So this is our game room. We don't do a lot of, going out to concerts on the weekends. This is where we spend our money on these games.
she expects to be back playing board games and going for walks with her dog Comet.
I'm gonna have a whole lot to be thankful for.
And we are so glad to have Allison in studio with us today. We're going to catch up with her. And next to her are two of her doctors, Jamie Wagner and Ann O'Day. Dr. Wagner is a surgical oncologist and the division director of breast surgical oncology. Dr. O'Day is breast medical oncologist and medical director of the breast cancer survivorship program. And across from me, we are joined by Dr. Jasmeet Asi, a pathologist specifically trained in breast pathology. And we're going to learn exactly what all of that means and how this team comes together here in just a moment. But first, Allison, I have to ask you, tell us a little bit about the status of your cancer and, of course, how you're doing today.
I am doing amazing today. I'm feeling so much better. It's a road to recovery after you go through the whole shebang of chemo and surgery and radiation and all that thing. But I think my energy levels are getting back up, and I'm getting back to a sense of normal, maybe perhaps a new normal for me. But I'm feeling awesome, and happy to say that these wonderful team helped me be able to say that I am now cancer-free.
Well, they have been beaming all morning since they saw you this morning. I know I'm speaking for them. They're so glad to see you. But when you spoke on our program a few months ago, you had not yet started radiation. So what was radiation like?
It was not too bad, actually. I did 15 different treatments, so I had to go every day for 3 weeks, Monday through Friday. I went to the cancer center there in Lee Summit, which is where I live, so it made it a little bit easier for me to travel. It was maybe about 45 minutes out of my day, no problem, and everybody there was so nice, and then the after effects were not too bad at all. So.
Good. Yeah. Dr. O'Day, from your perspective, how is Allison doing?
She's fantastic. She speaks for herself. When I walked in today and I saw her with her new cute short hair, it just makes me so happy, and I just see her, thriving as a mom, as a woman, and it just makes everything worth it. So, thank you for letting us see that today.
Well, we want to today focus specifically on this change in diagnosis. Originally, another hospital had said that Allison had triple negative cancer. Then the pathologist here at KU, at the cancer center here at KU, they find out that the cancer is not triple negative. So, Dr. Wagner, how often does a change in diagnosis happen once a breast patient, a cancer patient comes here?
Well, the interesting thing that we have seen through some studies is that approximately 33% of the time when a breast-specific pathologist relooks at the original pathology, they will find a different histology, and 25% of the time the prognostic markers change. And when we talk about prognostic markers, I describe them as the personality type for the breast cancer. It's how it behaves, and that's exactly what happened with Allison, is that we went from a triple negative cancer to a hormone positive cancer. Dramatic change in how together Dr. O'Day and I treat her.
And a common theme we're going to talk about today is that importance of getting a second opinion at a place like ours. So Dr. Ossie, as a pathologist, help us understand how the team here is able to find things that maybe other places might miss.
So here at KU, we're more of a subspecialized practice where there's a bunch of us that do breast pathology only, or mainly breast pathology, liver pathology, lung pathology, and so forth. And with this, there's 7 of us or 8 of us which know quite a bit about breast pathology. And as for other institutions or the generalized pathologist, they would look at all types of cancers. And they're not looking at the same complex cases that we do on a daily basis here. And because of that, we notice the subtle changes and the subtle differences that an outside pathologist may not be able to. And thus, this is how we change diagnoses here all the time.
So you're seeing cancer literally through a different lens, so to speak.
Yeah, of course.
In Allison's case, the diagnosis switched from triple negative to being estrogen positive. Are you able to tell the difference under a microscope?
Yeah, under the microscope, we're able to see all these different changes. As in Allison's case, it was triple negative, and that meant that all 3 markers, the ER, PR, and HER2, were all negative, and that would mean the negative staining or not staining of the slides under the microscope. However, in her case, it was actually positive when I looked under, well, not when I looked, but when we do look under the microscope, you can see positive staining cells for ER in her case. And yeah, that's how we can make the difference from triple negative going all the way to ER positive, which have great repercussions in treatment.
So Dr. O'Day, I remember you saying before that you do not like the term triple negative. Why, first?
I just don't like that connotation of triple negative. The reality is, when we use the term negative, it implies a negative test result. Negative for estrogen receptor, negative for progesterone receptor, and negative for HER2. But to patients, that I think it has just a lot of, that has a lot of negative connotation. So I wish it was described as triple absent, or that those receptors are absent on the surface of the cancer cell. That helps patients understand more about what we're talking about. I think a lot of times they think triple negative, that means I have a triple bad prognosis, which means we have to treat it more aggressively, and so on and so forth. And I think one of the things, not to brag on Jazz and our pathologists here, but there is so much that we're learning about breast cancer specifically and about tumor heterogeneity that breast cancers very rarely are just like one thing and purely one thing. I explain it to patients, and this might sound really silly, but sometimes these cancers are sort of like a bowl of trail mix, and in there's peanuts and raisins and M&Ms, and some cancers are 99% peanuts and only 1% occasional raisin or M&M. And if you don't have a pathologist that's used to looking for that one isolated cell, you're going to miss that. And the treatment that we are going to recommend is only as good as the accuracy as what he tells us. We always tell our patients, and I probably told this to you, that the most important doctor on your team, it's not Dr. Wagner, it's not me, it is the one doctor you usually never meet, and that's your pathologist.
Well, which is why we're having this program, because I don't think a lot of people would know that. Dr. Wagner, and anyone just jump in on what would someone like Allison, who isn't here yet, she's at another place across town perhaps, how would she know to ask that? And until she got that ding on her phone, she didn't know that this had changed on her.
Right. It's a hard question to ask. You know, when you first get the diagnosis, the first thing is get it out. So they're looking for a surgeon. And then what other treatment do I need? And they know they need an oncologist. But an important part of that needs to be, where did I get diagnosed? And if it is not at an NCI designated cancer center, that really should be the priority next step of, let me get a second opinion. Because the data also shows us that 43% of the time, breast cancer specifically, the diagnosis will change by getting that second opinion at an NCI designated cancer center. And as a result, if we change diagnosis, just like what we're talking about, everything changes about treatment. You know, very much like Dr. O'Day is describing, we use a lot of analogies because we've got to portray what we're seeing under the microscope, seeing on a report, to helping patients understand. So the pathology is the foundation for the treatment house that we're going to build. Right? So if we get the foundation wrong, what happens over time? It crumbles, and it is not sustainable. And that is where patients' treatment responses are not going to be as good, and then we sacrifice survival. And we are not willing to sacrifice survival for a single one of our patients.
So Allison, what do you remember about getting that new change in diagnosis?
I remember it very vividly. It was the day I was to start my chemotherapy treatment. I had a 1 o'clock appointment to start my chemo, and I get a phone call from Dr. O'Day around 10 o'clock in the morning. Sitting on the couch with my husband. I had already, gotten sick that morning because I was so nervous about what was to happen that day. And when I got her call, it was just like a sign of hope. You know, I immediately had a sense of relief that, I think this is really scary, but I've got a good team behind me, and they're gonna get me through this. And so it was that was my immediate response. But then after being happy and relieved, I kind of got a little mad and questioning what would have happened if, because she had to change my course of treatment. Within 3 hours, I was going to have treatment, and she changed it 3 hours before I was going to do it, based on that result.
So, Dr. O'Day, how did it change?
It changed her chemotherapeutic combination of drugs that she was receiving. It changed the schedule of the drugs. It changed the number of treatments. But most importantly, for women that have estrogen-driven cancers, which is 80% of all breast cancers, for women that have estrogen-driven cancers, those anti-estrogen or estrogen-modulating medications improve their survival by 50%. And so if we had not known this, we would not have offered her a medication that would improve her survival by 50%. So it's critically important.
Dr. Wagner, when do you usually get that report in all of this?
Well, when do we get it? Most commonly after the percutaneous biopsy. So they go to breast imaging, where the abnormality has been seen on a mammogram or ultrasound, and then they do a biopsy that's guided by one of those imaging modalities. It's amazing how far we've come, because even that's where breast pathology is an equal part of this conversation of what we see and how we do it. You know, we used to do fine needle aspirations where we just took out cells. We couldn't get all of this information before. Now we can actually take out the strips of tissue, so the complete prognostic marker complement of the estrogen, progesterone, HER2 can be seen by our pathologist, really revolutionizing how we treat patients. By having that information now up front, together we strategize, because sometimes medications are needed first. Sometimes we need to go to surgery first to get even more pathology information for the medical oncologist to continue to make that plan. It also influences radiation treatments. So getting it right from the beginning is how we put everything together lock and key perfectly. And that has just shown to have really great outcomes for patients.
Dr. Ossie, I noticed these ladies are very tight-knit with you.
Yeah.
They look to you
Totally.
for the best information. Tell us a little bit about how you all communicate.
They all know I give them a call any single time I'm about to sign out a case if something looks off or something doesn't make sense to me. And we all as a team come together, and I do call my radiologist, I do call my surgeon, I do call my oncologist, and to make sure everything matches and everything makes sense before I release the report. And seeing if anything else is going on with the patient that I don't know about, and that's usually how we do it.
So what questions should a patient be asking about a pathology report? I wouldn't even know to think to ask about it. I just think there's a report out there, someone's looking at it, and they've got it right. Should they be asking questions?
I think one of the things that's valid to ask is, who were the pathologists that reviewed this? Was there more than one pathologist? What is their area of expertise? Those are all very fair questions. Just like before you come to a consultation with myself or Dr. Wagner, you may look up our training, our credentials, our board certification. That holds true for a pathologist as well. And one thing I do also want to highlight is I often get cases where patients come for a second opinion after they've already had surgery at maybe a local hospital or a hospital in their hometown. And there are many wonderful and talented surgeons at these other locations. And they meet that surgeon and they have the consultation and they say, well, I really like this surgeon, I trust them. But what they need to understand is it isn't just about the surgeon, because where you have your surgery is where your pathology will be processed. So if you do choose to have your surgery at another location or at your local location, you can still ask to have that reviewed at an academic center, at an NCI designated center.
So basically ask the question, has Dr. Ossie seen pathology?
Or that.
Then we know it's in good hands. So I want to show some video because Allison, you were kind enough to let us take a video inside while you're having your lumpectomy surgery. And Dr. Wagner, there's a moment during this surgery where you took a sample from Allison and then you put it into a specimen container and then you send it off to the lab. Explain what that was and what information you were hoping to get back from that.
Yeah, those specimen containers are Dr. Ossie's favorite because he gets 100 from me in a case.
I bet.
There are several things. So our philosophy from the breast surgical oncology standpoint is pretty much if it comes out of a patient, it's going to go to pathology. Every bit of it matters. So there are going to be breast specimens. If it's a lumpectomy, such as in her case, then we're looking for clear margins. That's a very, very important aspect of everything. The cornerstone of good cancer surgery is you get the cancer with a clean room of tissue around it, whether that's with a lumpectomy, and I think that might have been the first specimen, or even with a mastectomy. Large cancers also still have to have clear margins. So the technical aspect of mastectomy is very important as well. She also had a sentinel lymph node biopsy, and that was the other aspect of specimens because we want to assess lymph nodes for what we call pathologic staging. And again, that lymph node information is more information that helps Dr. O'Day as well as the radiation oncologist continue the treatment plan to make sure that from a multidisciplinary standpoint, we are optimizing every aspect of treatment.
And Dr. Ossie, not all reports are the same. What's a synoptic report, and when's that necessary?
So a synoptic report is actually part of the pathology report. Anytime there's new cancer diagnosis, we always issue a synoptic report, and these are usually for excisional specimens, as mastectomy or lumpectomy. And in the synoptic report, we usually highlight all the main characteristics of the tumor, whether it be the margins, how far they are from the margins, the size of the tumor, the grade of the tumor, if there's any lymph node spread. And this information is quite important for the patient, so the patient knows more about their own cancer, as well as the whole team, the surgical team, the oncology team, to proceed and how to treat the patient.
Okay, this is where I make you uncomfortable and have to brag on yourself just a bit, because the docs here have done that, but I want to find out a little bit more, because you are fellowship trained in specifically, as we mentioned, breast pathology. Yeah. So what does that mean, and how does that make a difference for patients and patients like Allison?
So after residency, I did a year of breast pathology fellowship, and that was at UPenn. And at that time, every single day, we'd be looking at complex cases day in and day out, where it's also a big consult center too, where cases all over America and the United States as well as the world would be getting cases at our institution, and I'd have the opportunity to look at all these complex cases and the most difficult ones. And with that, and with all that knowledge and all that training, it makes us make accurate diagnoses here, and as for Allison's case, the right diagnosis.
So earlier this week, we had a survivor on our program who had 2 different types of cancer at the same time. How does that make things complicated. That sounds very complicated from just saying that, but two types of cancer. So from a pathology aspect, and then we'll have our doctors and breast cancer chime in on that.
So it doesn't make my job much harder at all. Looking at in the breast, if you see two different cancers on it, they'll have different morphology. And what I mean by that, the cells may look different from one another. The spread might be different. They may be in groups, or they might be singly dispersed. And with that information, I'm able to tell whether or not you're dealing with 1, 2, or 3, or even 4 different cancers in the breast. It probably makes our surgeons and oncologists' job way harder, though.
Is that like the trail mix you're talking about?
Absolutely. That is the
Thank
trail
you for
mix.
the analogies help.
Yes, and the key here is that what he said, it's not hard for him because of his specialized training. So when he looks under the microscope, he recognizes very quickly peanuts and raisins, where an average pathologist may say, oh, I see peanuts, I'm done, and here's my report. And then that individual's treatment is going to be based just on that one piece of information instead of the totality of the whole story of what's going on with that cancer. When it comes to treating, whichever is the worst prognosis, we're going to gear our treatment towards that, but make sure that if there is a treatment modality that could help any one of those types of cancer, that we incorporate that into the whole treatment plan.
Dr. Wagner, anything to add?
No.
Okay, no, she's got us covered. So if you have questions, I know I have lots, but please use the chat on YouTube or Facebook. You can tweet us or email the Medical News Network. Info is right there on your screen. Right now, let's get a check on our COVID count on this Friday. Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control. Good morning.
Hi, how are you?
Hi.
Yeah, peanuts and raisins always better than Franks and beans.
Thank you for that.
Right.
Good analogy.
So
coming
yeah,
from
so
you.
for our COVID count, COVID is always important. We know there are specific populations that are more at risk than others, but we have some other issues that we'll be talking about as well. So right now for the COVID count in the hospital, 21 active patients, and a few of those in the ICU as well. That number has been plateaued, been in those low 20s now for a few weeks.
All right. Doc Hawk, 2 infectious diseases we want to discuss with you this morning, hepatitis A and measles. First off, the Kansas Department of Health and Environment sent out an alert yesterday saying that they detected hepatitis A in wastewater in Lawrence, Kansas, and then they asked doctors to make sure that they are vaccinating 2 specific groups of people who use drugs and people who are homeless. Why the focus on those 2 populations?
Yeah, I think this stems from actually an outbreak that KDHE put out an alert in early January about a Shawnee County hepatitis A outbreak that was going on, that was being seen in that homeless or home insecure and people who use drugs population. We know that these infections don't really adhere to demographics or borders, and they can spread out into the community as well, and other demographics members as well. But I think that is the first impetus at this point as to why they're recommending that specifically for those 2 groups. But when I worked as an infectious disease investigator for the Kansas City, Missouri Health Department prior to medical school, I had to work on a hepatitis A outbreak in the Kansas City area as well. Hepatitis A outbreaks do occur randomly throughout the country and throughout the world, really. So it is not anything new. They can flare up, but it is important to remember we have a very good, safe preventive measure for these for this infection, and that is vaccination. Vaccination does prevent illness, and illness can be bad. So the other issue with this is you may not develop symptoms for about 4 weeks after you're initially exposed, so it's really hard to say exactly when you got sick. But we know that vaccination, even 1 dose of the vaccine, of the 2-dose vaccine, really helps to provide protection for most people. So it is very important to remember that and understand that as well. If you or your children are not vaccinated against hepatitis A, certainly recommend to go get it, especially if you're traveling. I know there's a lot of travel recommendations if you're going to certain countries to be vaccinated anyways, but it's an easy vaccine to get, and it's extremely safe.
All right, Huck, thank you. Let's address measles now, because there's an outbreak happening right now in a Florida elementary school. There are 6 known cases and many more unvaccinated kids at that school. But what's more concerning is kind of this hands-off approach from the Florida State Surgeon General. And it sounds like instead of enforcing the normal isolation guidelines, he's letting parents decide if their kids should stay home or not. And Huck, I know that you are personally slightly frustrated when you hear things like this.
Yeah.
Needless to say. So what's supposed to happen during a
Yeah.
measles outbreak?
I mean, I think it would be a charitable comment to say this is one more of few guidance measures that the Surgeon General has stated that is just plain wrong. So, you know, measles is very contagious. It is probably the most contagious vaccine preventable disease that there is. Right now, the recommendation is that if you are not vaccinated, if your children aren't vaccinated, they should be held home from school for 21 days. Why is this? Because measles is not innocuous. So unfortunately, or fortunately, we have a recency bias right now. We don't understand really what the full disease process is, what the ramifications are for those children that get the disease, because most of us have all had measles vaccine, and we haven't had to deal with that in our daily lives growing up or in adulthood. But in fact, measles can be quite severe. So 1 in 5 kids can go to the hospital for various reasons, things like diarrhea and dehydration, but also more severe things like pneumonia. 1 in 20 kids can get pneumonia, and unfortunately also 1 in 1,000 kids can get a central nervous system type infection or side effect or problem with that infection. It can be encephalitis, it can be losing their hearing, so many different problems that can happen with this virus, unfortunately. The other issue with this, although not as long as hepatitis A, is that it can take up to 2 weeks to develop symptoms, so you don't even know right away if your child has been exposed. But the easiest thing to do is go get measles, mumps, rubella, MMR vaccination. Protect your children. The vaccines are very old, they're very well tested, they have an excellent safety profile, and they do protect you and your children from this disease. And we always hear parents talking, whether it's influenza or other infections that could have been reduced or prevented with vaccines. If their child does get infected and suffers consequences, they always say, I wish we would have gotten vaccinated. So it's vitally important. Go get your hepatitis A vaccine, especially if you're living in those areas, Shawnee County, Douglas County, it's very important. And of course, everywhere we continue to endorse those vaccine preventable disease vaccines, especially through childhood. Make sure you and your children are up to date.
Hawk, we have a question for one of our viewers. Is it true that you cannot get Paxlovid paid for by the government anymore?
You know, they did have a program. I'm not sure when it ended. I think Medicare still pays for it. I'm really not sure. I think it is specific to each individual. I know that the government program had ended, but they were going to continue the subsidized or the paid for Paxlovid as long as the supplies lasted. And the last I had heard, there was a lot of supply, so it's just unclear where they're at in that supply range at this point in time.
All right, makes sense. Hawk, thank you so much. Let's get to some other questions from our viewers this morning. And Gene just had a comment. He says, boy, this is such an important program, not just for breast cancer, but the importance of getting that second opinion. And a question from Jeremy, are there cancer behaviors that tip you off that need to take a closer look at, that you need to take a closer look at the pathology, or is the pathology deep dive part of the treatment for each case? Like, do you ever go back and say, we got to look at this a little closer? How does that go?
Yeah, usually when we look at some of the breast cancers, high-grade cancers usually mean negative receptor markers, and usually if that doesn't make sense, we'll go back and ask more questions or get additional testing done to make sure that everything was done correctly.
So on that note, another question was, after a biopsy, how many tests can be run on a sample?
So generally, when we do get a breast biopsy, and usually we mainly do them on biopsies up front, if it's a benign or negative or no cancer case, we usually don't do any testing on it. But however, if it is a cancer case, we usually get 4 markers, which is being ER, PR, HER2, and Ki67. And as we've been talking this whole time, it does dictate how treatment and prognosis happens with the patients after we release those reports.
Allison, after listening to your story, a viewer wants to know just how was the holiday season for you and heading into this new year? How has the outlook been with you and your family?
Oh, wonderful. I mean, obviously I wouldn't have asked for this diagnosis, but it sure has given me a whole new outlook on life, a whole new perspective. Things that were important before just aren't anymore. And so just really being able to enjoy a life and get the most out of it, because being faced with that, it kind of puts a whole new tune to your step. So
I bet. Last quick question for you, Dr. Ossie. What's the coolest, fanciest, high-tech piece of equipment up in the lab, and what does it do?
Well, I would say the most important one is my microscope, because that's where all the diagnosis is gathered.
Yeah, right?
And for in the lab, and Dr. Wagner would agree with me, is our Faxitron machine, and that's where it's a tiny X-ray machine where we X-ray all the breasts that come through there to make sure that the mass or the cancer is taken out completely, so we can look at it after under the microscope.
Let's get our takeaways today on this Friday. And Dr. Ossie, I'll stay with you. What do you want folks to take away today?
When you do get your pathology report, ask as many questions as you want to your surgeon, to your oncologist, even to your pathologist. And if you ever have a hunch or you want a second opinion, don't be scared. Get a second opinion. It may change your diagnosis as well as your treatment plan. Dr.
Wagner, what's the takeaway today?
I think what mine frequently is you need to be your own advocate. And that is part of what we're really talking about today, is if you feel in your gut you should get a second opinion, just like what Allison talked about. Get a second opinion. Nobody cares about you as much as you do.
Dr. O'Day, what's the takeaway?
Just that when you do that, when you get a second opinion, if it does change your diagnosis, it might open up a whole new realm of treatments. It also might open up an opportunity for you to participate in a clinical trial with a new drug or a new surgical technique that might benefit you greatly. So again, if that foundation is off, everything we'll recommend, not only in terms of treatment, but in terms of clinical trial participation, will also be off as well.
Such important information today. Allison, I'll let you wrap it up. What's the biggest takeaway from your personal story?
If you get diagnosed with cancer, come to the University of Kansas Cancer Center.
Thank you for that.
Period.
You're hired. That's great. Well, we're so glad that you're doing well. Thank you for sharing your story, because we can't inform the public without your words and your story.
Happy to help. Thank you for having me.
Thanks to all of our guests today. Thanks to all of our viewers for being with us. We'll see you back here on Monday. Coming up Monday on the Morning Medical Update. A farm accident cost Connor Cox his hand, but bionic technology is letting him drive his tractor, feed his cows, and provide for his family again. I'm Jessica Lovell on the next Morning Medical Update, the special surgery that lets Connor's own muscles communicate with his bionic hand. Monday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.